My name is Professor Michael Polkey. I'm delighted to introduce this short film about the sleep service at OneWelbeck Lung Health. I'm a consultant here. I'm also a consultant in the NHS, and I hope you'll find the video helpful. Here at OneWelbeck Lung Health, our sleep service is really focused on identifying and treating a condition called obstructive sleep apnea, which we'll talk about later on in this web video. It is fair to say that there are other sleep disorders which require more specialist equipment to assess, and we're not currently equipped to do that at OneWelbeck Lung Health, although we may be in the future. The purpose of this video, though, is really to focus on obstructive sleep apnea and the related condition of snoring that can be very burdensome for many people. Obstructive sleep apnea is a very common condition which can cause a number of problems, so I think it's important that we understand what it is. As I'm sitting here, my throat is a nice smooth pipe that I can breathe through, and I'm very happy. When I go to bed, that pipe goes from being vertical to horizontal, but I can still breathe quite happily. However, when somebody with this condition goes to sleep, the muscles in the airway here relax, and at that point, if the circumstances are otherwise unfavourable, the airway can collapse like that, and at that point the person is unable to breathe through their airway. And if you can imagine it, we have a closed airway here, we've got their head here, and here we have their arms and legs and all the other parts of their body. Now, if the airway is closed, eventually the patient's oxygen level is going to fall, and at that point they will wake up. When they wake up, the muscles in the airway here start working again, and the patient is able to breathe again, and the oxygen supply is restored. Now, there are good things and bad things about that. The good thing, of course, is that the patient is not going to die from the airway closing, because they always wake up. But the bad thing is that the awakening, if it's frequent enough, can cause significant disruption to sleep architecture and daytime tiredness. We also believe that the oxygen level, which falls when the airway is closed very often, can cause damage to other parts of the body. So, as I say, somewhat of a double-edged sword. The patient with this condition is always going to wake up, so they're not going to die in their sleep, but they may have very poor quality sleep, which will affect how they are in the daytime. How does sleep apnea affect you? Well, clearly if you have disruption to your sleep architecture, you're likely to feel tired during the day, and if you're not sure how tired you are, I would suggest you consider completing the Epworth score. This is something that can be downloaded from a number of websites, including the British Lung Foundation, but generally speaking, a score of 10 or more indicates that you're more sleepy than perhaps you should be. Patients with sleep apnea also often feel unrefreshed on waking and would readily go back to sleep if they could. The sleepiness can lead to a problem with daytime functioning in lots of different ways. It certainly increases the risk of road traffic accidents. It may lead to difficulty at work. We've had patients, for example, who have fallen asleep at work, which has led to obvious difficulties. It may lead to other slightly more subtle things like a bad temper or a short fuse, if you like, or difficulties with memory. Sleep apnea is also associated statistically with a number of other diseases. So amongst people with sleep apnea, certain diseases are more common, but of note, high blood pressure, atrial fibrillation, diabetes, other manifestations of cardiovascular disease, and in men, erectile dysfunction. So people with those conditions, if they are proving hard to treat, it's always worth just asking the question, could sleep apnea be in play? And the simplest way to answer that question is to ask about a history of snoring or to complete the Epworth score as a first off. Restless leg syndrome is a condition where the patient has fidgety legs, and you may have met these people socially, but these are people who can't sit still. So if they're sitting, as I am now, instead of sitting calmly, they might be sort of jiggling their feet a bit like this, and their symptoms are improved when they move about. So quite often such people will make an excuse to go to the loo or something so that they can get up and walk about and relieve the symptoms that are disturbing them. Now, there's a related condition that we call periodic limb movement disorder, where the patient's limbs move at night for reasons that are not totally clear, but the limb movement itself wakes the patient up and fragments the sleep architecture and can cause all the things that go with disrupted sleep architecture during the daytime, including daytime sleepiness. Now, people who have the leg movement at night don't always have the leg movement in the daytime, but they often do. And the condition is associated with low iron stores. So one of the things your doctor will do if he or she diagnoses the condition will be to measure your iron status and arrange iron replacement if necessary. But if iron stores are adequate, then there are some drug treatments that can be helpful in this condition. What are the common causes of sleep disturbance? Well, it is fair to say that very often sleep disturbance is if you like, behavioural in nature, so insomnia, and sometimes that's appropriate. So we know that if we, for example, have lost a loved one, that we're maybe not going to sleep so well for several weeks or months. Sometimes it's just part of life. So if you live next door to noisy neighbours, or if you have small children, you're quite likely to be woken up at night. But there are also some specific sleep disorders. In adults, the two commonest sleep disorders are obstructive sleep apnea and also a condition called periodic limb movement disorder. And both of those we can identify and treat here at OneWelbeck Lung Health. I mean, in general, if you need a long sleep time, so in the business we talk about sleep opportunity, and most adult humans sleep on average for, let's say, 7 3/4 hours, but we can call this the 8-hour sleep. Now, if you're somebody who needs 10 hours of sleep, for example, that could just be that you're at one end of the normal range, but it could also indicate that you have a sleep disorder. So if you require a very long sleep time, it's certainly worth checking on the sleep quality. I mean, there are also other things that come around with sleep. So I think perhaps the most common one is whether you're a lark or an owl. We know that some people like to get up very early and go to bed very early, and other people like to go to bed late and get up late. And again, that's perfectly normal up to a point, but when circadian rhythms become very abnormal, then it raises the question of circadian rhythm disorders, which are a rare family of diseases, often with an underlying genetic basis. The pathway for investigating sleep disturbance is sort of straightforward. We tend to recommend that you first have a consultation with a sleep specialist. The purpose of that, of course, is to understand your symptoms better, both to try and get a clue as to the cause, but also to understand their severity. But we do also accept open access referrals here at OneWelbeck Lung Health from general practitioners and other specialists who are not sleep specialists. But either way, at some point, if there's an issue, you're going to need to meet with a sleep specialist so that he or she can evaluate your symptoms. At some point in the journey, either before or after you see the specialist, a sleep study is likely to be necessary if we want to understand what is the cause of sleep disturbance, because it's really difficult to get further forward without some data. The sleep studies that we do at OneWelbeck Lung Health use a home sleep study equipment, so you will sleep in your own bed, but you would come up here one day to pick up the equipment and then bring it back to us the following day, and then we download the data, and myself or one of my colleagues will analyse the data and prepare a report, and that can form the basis of a consultation to decide about treatment after that. It's impossible to, of course, give a comprehensive guide in a short video, but in terms of where the journey might take you, if we find obstructive sleep apnea, then the treatment will depend on the severity of the condition. Sometimes if it's very mild, we actually don't need to do any treatment, and it's simply enough to reassure the patient and their partner that sleep apnea is mild. But if it is more severe, then there are a number of other options in play. The first thing, of course, is conservative management, and where the patient is overweight, we would advise them to lose weight. However, very often I find that, of course, the patient is aware of that already and has not been successful in doing so. The second line of treatment for milder cases of obstructive sleep apnea might include positional therapy. We find that some patients are much worse when they sleep on their back than on their side, and that's data that comes out of the sleep study. And where that is the case, there are a number of mechanical approaches that can be used to avoid sleeping on your back. And again, for some patients, that's sufficient to solve the problem. The second approach for people with milder disease is to use a dental device. Now, this is a little bit like a gum guard that a sportsman might wear, or if you have children, you might find your children are wearing it to play hockey or something like that. But essentially, whereas a sportsman has the gum guard in a neutral position, what you want for sleep apnea is to push the lower jaw forward like this. And these devices anchor onto the top jaw and push the lower jaw forward in that way. So you do, of course, have to have healthy teeth to do that. But again, that's a good solution for many patients, and of course is very portable. The gold standard treatment for obstructive sleep apnea, though, is what we call CPAP. CPAP stands for continuous positive airway pressure. And if you remember, we realised that the problem is about airway closure here. And what CPAP is a mask that's worn typically over the nose, or sometimes the nose and mouth. And the mask is connected by a pipe, a 2-metre pipe, to a unit that sits on the bedside table. And the unit on the bedside table is actually simply a blower. People often think it contains oxygen, but it doesn't. It just blows air from the room down the pipe and through the mask, and the air pressure holds the airway open from the inside, so it's a kind of pneumatic splint, if you like. Now, not everybody is wild about having to wear a mask at night, and I don't think so many people would if it wasn't highly effective at relieving the sleepiness that's associated with sleep apnea. But thousands and millions of people use this therapy worldwide because actually it does work. Now, the common questions that come up with this are, will I be able to move around in bed without strangling myself? And the answer is yes, you can. The pipe is long enough to do that, and no one's ever strangled themselves. And sometimes one's partner or spouse is concerned about the noise of the machine, but the important point to note here is that the machine will take away the snoring. So from the spouse's point of view, this is a big advantage because the machine itself just makes a small hum, a little bit like an air conditioning unit at most if it's correctly adjusted, and is much quieter than the snoring that people with obstructive sleep apnea typically have. People often ask about surgery for snoring and sleep apnea, and I think it does have its place, but we have to be clear that upper airway surgery is not really a treatment for sleep apnea, although it can be useful for snoring. And I think our recommendation as physicians would certainly be that anyone who's entertaining the idea of upper airway surgery should have a sleep study first to make sure that they do indeed have simple snoring and not anything more sinister. From a surgical point of view, the other point that I often make to patients is that weight loss surgery is a very good option for addressing sleep apnea, because if you can successfully lose weight, you will certainly improve the severity of sleep apnea, which may mean either that different treatment options become available, or indeed that you don't need treatment at all. And of course, it goes without saying that weight loss is good for one's general health. Sometimes people just have bad sleep without an underlying sleep disorder. In fact, that's very common. There's innumerable sources of self-help for this, but what I realise as a sleep professional is that sleep, what we call sleep hygiene, is very important. Now, that doesn't mean washing, although we are in favour of washing, but what it means is just be sensible about your sleep. So if you have difficulty sleeping, then, for example, don't have any caffeinated products after midday. Now, people often don't appreciate there's a lot of caffeine in things like Coca-Cola or Iron Brew. Your bedroom should be quiet and dark. We know that light-emitting devices are a stimulus to stay awake, so if you are having trouble sleeping, we don't recommend using iPads before you go to bed. Use a paper book or a Kindle or something that doesn't emit light. As a general tip, the bedroom we think is for sleeping, so we don't encourage people to eat in bed, to do their work in bed, to watch television in bed, and do lots of other things in bed. Now, of course, if you can sleep fine while doing those things, that's absolutely fine. But if you are having difficulty sleeping, you need to do that. And then the final tip I would give people is that if you are having difficulty sleeping, insomnia in effect, don't stay in bed, because if you do, then over a period of time you will form poor psychological relationships with your bed. So if you're having difficulty sleeping, don't stay there and look at the ceiling. Please get out of bed, do something else, have something calming like some chamomile tea, for example, if you like, that sort of thing. And then once you've been out of bed, go back and have another try getting to sleep later on. Well, if you're concerned that you have a sleep disorder, often the first port of call classically would be to go to your general practitioner. He or she will, of course, inquire what the problem is and may want to do 1 or 2 questionnaires of note, the Epworth score, which is widely available. If you prefer, in terms of what we offer here, we do have sleep specialists who would be very happy to consult with you and to try to understand your symptoms better, and if necessary arrange onward investigation. In terms of referral, it's possible to refer yourself, but be aware that different health insurers, if you have health insurance, have different views about sleep, so they don't all cover sleep, and many of them will want you to get a GP referral first rather than referring yourself. People often confuse poor sleep and sleep-related disorders with just the passage of time and being part of life, and indeed sometimes that is the case, but it doesn't have to be. So what I would say is, if you do think you have a sleep problem, then please talk to someone about it. It's not something that you have to suffer in silence with. Similarly, I'd just like to make a little bit of a plea about snoring. I think there's a tendency in these times when the health services are a bit stretched to think that snoring is either normal, which it's not. It's certainly common, but I wouldn't say it's normal, or something that you just have to live with. But again, there are things that can be done about it. So I think if it is causing domestic distress, then it's worth speaking to somebody about it.